Hi everyone, this is Professor McCann and this is your lecture on stress and coping. Here are our learning outcomes. And so we'll start talking about the concept of stress as stressful situations, and they also usually involve three major types of stress: harm and loss, threats, potential or future, and challenges. When we talk about stress and coping, we want to think about what triggers stress in one person might not cause a stress in another. A stressor is defined as an external influence that threatens to disrupt equilibrium that is needed to maintain homeostasis. Homeostasis, one of my most favorite words, the body's ability to maintain a stable, balanced internal environment despite external changes. Stressors can be physical, mental, emotional. They can be positive or negative depending on a person's perception of what's going on in their experience. And stressors have the capacity to cause stress. Think about pandemic related stressors that each of us had and each of us had individual experiences with. I think that is a great example of how different things caused different stressors for different people. Additional sources of stress might be work, financial disruptions, discrimination, elections, being in nursing school, all potential sources of stress. So how does the body think about stress? So the body has a general non-specific response to stress, and that is placed on it by a stressor. Eustress, which is considered good stress, is associated with accomplishment or victories. So maybe like you trained for a marathon and then you ran it and you accomplished. That was a good stress. Or you studied real hard for the semester and you did really well in health concepts and you passed. Good stress. Distress is the opposite, and it's associated with inadequacy, insecurity, and loss. And then we have allostasis, changes necessary to achieve homeostasis. These might be psychosocial, physiological changes that occur as a response to stress. Many are triggered by the activation of the sympathetic nervous system, which triggers that fight or flight response. And at the same time, you'll get that release of epinephrine, you'll feel that increase in your heart rate, increase in blood pressure as a response to those stressors. We also have stress mediators that promote adaptation, so the body's not constantly in that flight or fight mode. And those are glucocorticoids and catecholamines. In ideal conditions, stress response permits the body to compensate for stressors. There is a physical cost of adaptation to physiological or psychological stressors. Besides hormones, these include behavioral responses to stress. So when we think about positive ways to manage stress, it might be yoga or exercise. If we think about maybe unfavorable ways we might manage stress, it could be smoking, consuming lots of alcohol, all which are negative ways to try to adapt to stress. Chronic, prolonged overexposure to stress mediators or not adequately being able to regulate stress can create illness. Coping is a dynamic process through which an individual applies cognitive and behavioral measures to handle internal and external demands that an individual perceives as exceeding available resources. So if you have a really hard test that you need to pass, how do you cope with that stress? Well, you study more and you read and you do test questions and all those good things. Integration of environmental cognitive measures to mitigate or diminish stress are positive. When an individual is unable to adapt to stress sufficiently to maintain homeostasis, functional impairment can occur. So let's bring it back to the healthcare settings. Nurses assist patients in distress all the time by assessing the source of stress and the patient's response, and by helping the patient cope with the stressors, helping them identify coping mechanisms. Nurses must know types of stressors, how humans respond to cope, or how humans respond to or cope with stress, and theoretical models of stress and coping. How people perceive stress varies, and so no two patients are going to respond to the same stress in the same way. And identification of a stressor depends on an individual's personal perception. So maybe having an IV inserted is very stressful for one patient, but for the other patient, it's absolutely no big deal at all. Certain stressors naturally evoke physiological stress response without regard to a person's personal perception. So let's talk about types of stressors. Biogenic stressors directly trigger stress response without any cognitive process. Examples would be caffeine, amphetamines, extreme temperatures. Psychological stressors are environmental events, either real or imagined. They facilitate activation of a stress response rather than directly triggering it, and it depends on how the, the person perceives the stressor. Both severity, length of exposure, and time affect the magnitude of the stress response. This is true for both biogenic and psychosocial stressors. Anticipation of a stressor can produce the same physiological response as an actual stressor. So, four types of categories of stressors: acute, time limited, sequential events following an initial stressor, chronic, intermittent, or chronic, permanent. The degree of stressors impact ranges from beginning hassles of daily living to a traumatic life event. Daily hassles are like the individual day-to-day tensions people face. Commuting, going to work, interpersonal relationships. They are more strongly correlated with somatic health symptoms than more eventful stressors. Person's physical, emotional, spiritual health affects whether a person views hassle as a minor inconvenience or a major strain. Health alterations may overwhelm an ability to cope even with a mild stressor. So if you have a patient in the hospital who's dealing with a significant health stressor, that may overwhelm their coping mechanisms, and any little thing that comes their way on top of that health stressor, they may not be able to cope with. For instance, you have a patient who's maybe dealing with a new cancer diagnosis, and they are completely overwhelmed and are unable to cope. But the next thing that happens is they get the completely wrong meal tray, and the next thing you know, they are screaming and yelling at you. And those two things don't necessarily align, but because the health alterations have overwhelmed that patient, they have no ability to cope with that getting the wrong tray stressor. Types of stressors: internal stressors. Internal environment within a person's being, a person's physical, spiritual, cognitive, emotional, and psychological well-being depends on satisfaction of basic human needs. When internal needs are not met, it's harder for a person to cope with change. The impact of chronic, life-threatening, debilitating illness has been identified as a significant stressor. Environmental stressors. External environmental stressors, triggers outside the individual that require change or disrupt homeostasis. Positive stressors, negative stressors. Stressors may be simultaneously positive and negative, and an event is a stressor if it creates a change in the person. So we're done talking about stressors for the moment. We're going to move on to the coping process. And we're going to start with the cognitive appraisal. After a person is exposed to a stress, it appraises the stressor. The primary appraisal is that first impression. Sometimes it's irrelevant, no meaningful effect on the person, or it can be benign positive, demands for change perceived as preserving or enhancing well-being, or it can be stressful, viewed as harmful, threatening, or disturbing. Then we go to our secondary appraisal, where we attempt to predict the impact of that stressor, the intensity, the duration, the necessary coping behaviors that we're going to need. And intensity of a stress response might seem incongruent with the stressor. So sometimes you may have a really big response to maybe what could be perceived as a minor stressor. It's important to understand that each person is unique, and based on their history or their past experiences, it may sometimes generate an incongruent response. Maslow's hierarchy of needs, we actually talked about this in the safety lecture. So 5 categories of human needs that have been proposed by Abraham Maslow, listed in order of importance. So physiological, food, water, shelter, all those things. Then we go to safety, security of employment, resources, health, property, all those things, followed by love and belonging, friendships, family, all those things, self-esteem, your self-perception of how you perceive yourself, confidence, achievements, those types of things. And then self-actualization, which is morality, creativity, spontaneity, problem solving, all those things. As each category of needs are met, a person's focus shifts to the higher order of needs. Meaning, if you don't have food, water, or shelter, it's going to be hard to make it to the next step, which would be safety. And if you don't have safety, then it's going to be hard to progress to the next step, which is love and belonging. Mental illness may lead to the exclusion of certain categories based on a person's underlying mental diagnosis and illness. So effective coping, it's a learned process. It's not an inherent personality trait. And I think more than ever today, we see that some people cope very, very well, and some people have no coping skills whatsoever, especially in healthcare where people almost always are under a stress when they are there. Nobody's coming to the hospital because they're having the best day of their life, unless maybe they're having a baby, and even then, that's still stressful. Coping is a means to manage or alter problem causing distress. You have problem focused coping aimed at managing or altering the stressor, emotion focused coping aimed at regulating your emotional response to the stressor, avoidance coping using behaviors or cognitive processes to just totally avoid the stressor, pretend like it's not even there. Approach coping, which is confronting or trying to change the stressor by a direct action. And meaning focused coping, reevaluation, and potentially reducing the appraisal of the threat, meaning you're going to reevaluate and maybe you're going to find that it wasn't as stressful or it wasn't the threat that it was first perceived to be. Any form of coping is an individual process influenced by the number of stressors. How many stressors do you have acting on you at once? The source, the type, the intensity, the duration of those stressors, and then the individual's support, experience, and vulnerability. As nurses, we must be aware of our own coping style, maintain non-judgmental attitudes about other people's coping styles. Whew, and that's a hard thing to do. Super, super hard. Think about that first empathy video that I showed you guys in class when we think about how we like to judge and think about other people's stressors. As we continue with the coping process, we're going to talk about reappraisal and adaptation. So, following attempts to cope with a stressor, a person engages in reappraisal, looking back at the stressor again. We evaluate which coping mechanisms were successful and which were not. We may make another attempt to respond to the stressor to return to homeostasis. And stress is not viewed as good or bad. Instead, it's according to how much, what kind, under what conditions stress is harmful or helpful. So sometimes stress can lead us to perform at a higher level, as long as it's not too much, right? It can't be overwhelming. Um, some people say, that additional little bit of pressure helps them focus and perform at a higher level. Adaptation is the use of physiological and psychological processes to come to terms with implications and outcomes of stressors. This is influenced by personal variables, cognitive appraisal of the stressor, genetic predisposition to illness, and behavioral responses to stress. There are theoretical models for stress and coping that as nurses we must know. So there are stimulus-based stress models, stress synonymous with stressor, life events that requires change or adaptation by a person experiencing it, and the exposure to that stress leads to physiological, psychological, and wear and tear. And it can increase a person's susceptibility to illness if it starts to overwhelm us. We have the social readjustment rating scale, SRRS, to numerically rate stress. It came way back in 1967. It looks at the impact of 43 life events such as death of a spouse, marriage, job loss, and there are both longer and shorter versions available. And then we have to look at perception of life events because it varies among individuals, particularly cognitive appraisal of an event being a stressor. Again, what one person perceives as stressful, another person may be like, yeah, that's no big deal. Somebody's like, yeah, I'm gonna go run 20 miles, and somebody else is like, that's absolutely crazy. If I had to run 20 miles, that sounds like the worst thing I could ever do. The impact of significant events may be affected by simultaneous exposure to routine stressors. Exposure to daily hassles may cause more stress alterations. So think about that as us saying that you are probably going to have simultaneous stressors put upon you, and our patients, while they're in the hospital with us, are going to be stressed by different things simultaneously. And then they may have just things in their daily life, just as all of us do, that are hassles that can cause additional alterations to those stressors and to our ability to cope. The response-based stress models. Stress is considered to be a response to a stressor. A stressor is any stimulus that evokes a stress response. And then we have the General Adaptation Syndrome, GAS. It's a 3-stage chain of events. There's the alarm reaction, which is the first stage, followed by the stage of resistance, and then the stage of exhaustion. Not every stressor triggers a general adaptation syndrome. Stress response may be global or local. The local adaptation syndrome, LAS, one organ or body system reacts to the stress. Example would be a local inflammation to a minor laceration, maybe on one of your fingers. The alarm reaction is the body's initial response, the shock phase. Your sympathetic nervous system is suppressed. The counter shock phase, the sympathetic nervous system stimulation triggers the body's defenses. Then we will go to the stage of resistance, where the body tries to move towards restoring homeostasis, still responding to the stressor. With chronic exposure to stressors, the body may maintain resistance to a primary stressor while resistance to other stressors may be diminished. So if the body is spending so much time focusing on one stressor, let's say the body is spending a lot of time focusing on a COVID pneumonia, that it can no longer keep up with the other stressors, um, which may be seen as, different alterations in health in other body systems. Maybe it was there chronically, like, the patient has underlying diabetes, but because of this stressor with the breathing, all of a sudden their blood sugars that were always in good control are now wildly out of control because the body just can't respond to all the stressors that are happening simultaneously with the same intensity and the same response. Prolonged physiological stress response may lead to increased susceptibility and illness. And then once we work to this stage of resistance, we can go to the stage of exhaustion, where the stressor overwhelms the body's ability to cope, or the body may rebound or disease may develop. The transactional model emphasizes a person's perception of giving a threat as a most significant factor. It incorporates an individual's differences in perceptions of stressors and responses to stress. A perceived stressor is an event or circumstance having the ability to negatively affect the well-being or appraised by a person as exceeding the person's coping ability. There is a primary danger posed by the stressor that threatens the person's primary values and goals. The process of cognitive appraisal will occur. And remember, those are primary appraisal, secondary appraisal, coping, and then reappraisal. That all comes under the transactional model. We have the nursing transactional model, which is an adaptation of the transactional model. It talks about the relationship between the nurse, the patient, and the environment in which they interact. So most of the time for us, it's going to be the nurse, the patient, and the hospital setting in which we're going to interact with each other. It is dynamic with each transaction. The person and the stressor engage to form a new transaction with a particular meaning each time, and it's going to be different. And one of the things within the nursing transactional model that is important is that we emphasize communication and the development of interpersonal relationships with our patients. This helps to decrease the patient's stress and to improve the patient's coping resources. This is viewed as a therapeutic interpersonal process, and the nurse goes from being a stranger to the patient to serving in many different roles for the patient. We are going to be teachers, we are going to be a resource person, we might be a counselor, we might be a surrogate, and sometimes we're a leader. We're leading our patients through maybe new health challenges, new experiences. Nurses have a very powerful and important role, especially when our patients are going through very, very stressful situations. Manifestations of stress. Remember, each individual is unique in their cognitive appraisal and coping methods. Individuals also may vary in terms of internal and external manifestations, and manifestations may be found in physiological, psychological, and cognitive domains. So manifestations of stress, how are we going to see those? So there are physiologic indicators. These result primarily from stimulation of sympathetic and neuroendocrine systems. They involve an individual's perception of potential stressors, triggers, and psychological manifestations. Prolonged exposure to perceived stressors can lead to disease and even be fatal. So you'll look at the diagram that I have to the right here on this slide, and it kind of walks through all of the different body systems, and it'll talk about the different things that happen at those levels. So when we have stress in the sensory, we might see our pupils dilate, which allows for entrance of more light and enhanced visual perception so that we can better understand what's going on around us. We also may have an enhanced awareness and alertness in response to severe threats. So those are going to be all of our sensory components. We're just going to have that heightened awareness to be really to try to take in as much information as we can from our environment. From an endocrine standpoint, we're going to see an increase in the release of glucocorticosteroids and increased glucogenesis, which leads to increased serum glucose. So when the body is under stress, patients may have elevated glucose levels for many, many different reasons. It doesn't have to be because of an illness. They can be under psychological stresses also that will elevate their glucose levels. From a urinary system perspective, there's going to be an increase in sodium and water retention due to hormones release, which will result in decreased urine output and increased blood volume so that there's more ability to circulate and elevate blood pressure if needed and keep your pulse wherever your body perceives that it may need to be in order to respond to the stress. Musculoskeletal, this is probably the one that everybody it has in common and we all can relate to. Musculoskeletal, we're going to see an increase in muscle tension in preparation for that fight or flight. From a skin perspective, we're going to see sweating, diaphoresis, increased body temperature, secondary to increased metabolism. The person may become pale, secondary to everything's becoming vasoconstricted. The body is really trying to clamp down and increase blood pressure and increase heart rate, which are side effects of norepinephrine. The respiratory system, we're going to see an increase in respiratory rate and depth of respirations. There's going to be dilatation of the bronchioles to facilitate increased oxygenation when the body's under stress. The cardiovascular system, it's going to try to increase the heart rate and cardiac output to promote transport of oxygen and nutrients throughout the body. So the heart is going to try to really do its best to try to make sure that it's keeping everything functioning at the top of its level as best it can to fight whatever stress that the body is encountering. And then we have GI. So we are going to see inhibition of the parasympathetic nervous system that will lead to decrease in peristalsis and maybe some constipation. You're going to have an increase in gas. You're going to have a decrease in salivation. So think about dry mouth when you get stressed. And then you're going to see an increase in serotonin levels in the gut, which can sometimes lead to feeling of nausea when you're stressed or overwhelmed. Phases of stress. You start out over here on the left with homeostasis. Then we move into phase 1, which is that stage of alarm. That's our body saying, okay, something's something's coming at us. How are we going to handle it? How are we going to deal with it? That's the shock phase. The body prepares for the cascade of the physiological reactions. And then also the counter shock phase, and the body's defenses are triggered. It's that self-protection phase. Then we have the stage of resistance, where the body attempts to move towards restoration of homeostasis. However, with chronic exposure to a stressor, resistance to other stressors may be diminished. So think about the example I gave you with somebody having a really bad pneumonia, and then maybe there are other chronic conditions that can't be as well managed by the body because the body is so overwhelmed by trying to deal with that pneumonia. And then we have phase 3, which is the stage of exhaustion. If the body cannot maintain its adaptation to the stressor, energy and the resources become depleted, and the body may rebound, or the disease may develop, and death can also occur. So let's talk about psychological indicators of stress. We have fear, that sense of apprehension that's triggered by a perceived threat to our safety or well-being. We can experience anxiety, which is characterized by apprehension, dread, mental uneasiness, a sense of helplessness in response to an actual or perceived threat to our well-being. Stress can manifest itself as anger, and I think we probably have all seen this at some point in our professional or personal lives, where somebody has this intense displeasure or irritation as a result of their stressor. And people can become depressed. Persistent, abnormally low mood, characterized by feelings of emptiness or hopelessness, sadness, or despair. And that can be, depression can be a manifestation, the way that stress is manifested. There are cognitive indicators of stress, so changes in mental processing. Maybe a patient will have diminished problem-solving capacity or cognitive structuring. You can see it manifested as impairments in a person's cognitive abilities, um, suppression, self-control, or maybe they just go the total opposite way and are fantasizing. They're not even really connected to reality anymore. So if you've taken Intro to Psych, we know the ego defense mechanisms, the unconscious psychologic process developed to defend personality, your sense of self. It's used to balance tension that emerges during stress and protect self from anxiety. So it's that automatic thing that tries to keep our anxiety levels balanced. Effects can be positive or negative. It is essential to psychological survival and protect. Our body will try to protect that psychological state. Nurses must identify defense mechanisms used by patients, but we must also recognize our own defense mechanisms. It is important to remember that defenses protect the person and the ego. Providing safe, non-judgmental atmospheres helps a patient let go of protective defenses and cope with reality. I think we can see this all the time with our patients, where they have their guard up or they are not ready to let go of those protective defenses and converse with you as the nurse to talk about the stressors that they are facing based on a diagnosis they may have been given, whether it's that they have their kidneys are failing and they no longer work, they have a new cancer diagnosis. There can be many ways or many different medical stressors that patients can experience, but we as nurses have to work to provide that non-judgmental atmosphere so that the patient can kind of let go of any defense mechanisms they may be using, to be open to having conversations with you about their disease process and start coping with it, to start dealing with that stress, so that it's not overwhelming them. There are additional concepts related to stress and coping, such as addiction, collaboration, mood and affect, perfusion, reproduction, self, teaching, and learning. So the DSM-5, which is what our psychiatric counterparts, anybody who's working in psychiatry, recognize as a manual that kind of really talks about classifying disorders related to stress and coping. We have anxiety disorders, we have obsessive compulsive and other related disorders, and then trauma and stress related disorders. Anxiety disorders are the most common mental health disorders in the United States. I don't think that is probably shocking to anyone. Uh, general, Generalized anxiety disorder, otherwise known as GAD, it affects 6.8 million adults in the United States. It affects twice as many women than as men, and it can develop at any time in the life cycle. Individuals at early adulthood are at the greatest risk. There are additional disorders, such as OCD. It affects 2.2 million people. And then there are patients and some of us that have phobias, which affect another 19 million people. So if you think about all those added up together, that's a huge portion of the population that at some point are dealing with some type of anxiety obsessive compulsive disorders, or a phobia. There are always genetic considerations and risk factors when we talk about anxiety. Many relate to, at first, unfortunately, to gender. Women are about twice as likely as men to develop an anxiety disorder. This may be correlated to a woman's sensitivity to corticotropin releasing hormone. Women are not more susceptible to every type of anxiety disorder. OCD and social anxiety disorders are equally common in men and women. Genetic factors. Anxiety tends to run in families. So if mom has an underlying diagnosis of an anxiety disorder, that can be seen then in the next generation in their children. Many children develop fears and anxiety similar to those of their parents. It's a learned behavior, and there may be genetic components also to that. Life experiences, exposures to trauma or significant events can trigger anxiety disorders in genetically susceptible individuals. And then if there's any history of spousal or childhood abuse or being bullied, those definitely can contribute to the development of an anxiety disorder. And there are also personality related characteristics. So those children who are shy and maybe not as outgoing are going to be more at risk for the development of an anxiety disorder. We as nurses will focus on health promotion. So we will want to work with our patients to focus on decreasing exacerbations of symptoms, identifying healthy coping behaviors for our patients. And for our patients who experience severe anxiety, they won't necessarily be able to retain new information and will require interventions taking that into account. And I think that's important when we think about when we're doing teaching for our patients, especially if they're very anxious and not coping well with what's going on during their hospitalization. Your patient most likely, even if it's just you and just them and there's no distractions in the room, if they are having such a high level of anxiety, they will not be able to retain many of the things that you may be reviewing or teaching to them. Same thing why patients don't retain medical information that's given to them. They are so overwhelmed by the stress of the situation and the anxiety that is being produced at that point that they just cannot retain it. Their body is doing all it can to keep up to try to create equilibrium again and get back to that homeostasis. The body just becomes very easily overwhelmed. Family wellness promotion is essential. Patients who may be victims of childhood abuse are associated with increased risk for physical, psychological disorders, and possibly for decades. These aren't when we have young children who are subject to abuse. They carry that with them for a very long time, and depending on the interventions that they receive or do not receive can determine whether they develop healthy coping strategies or poor coping strategies to deal with those. Even in abstinence of overt abuse and neglect, family dynamics and parenting styles may pose risks to a child's well-being. An example of that might be a disciplinary style that a parent has. While it might not be overt abuse, it still could be detrimental to the child. So for our nursing assessment, we're going to help patients identify stressors that trigger unhealthy coping responses and the potential effects of coping responses. Many patients with anxiety present with physical symptom complaints. Think about our patients who have panic attacks and severe anxiety and present with chest pain. The patient may be unaware or misunderstand the sources of those symptoms, and patients also may not want to disclose very personal information. It may take time for them to open up and to disclose to you what really is going on. So as nurses, establishing that therapeutic nurse to patient relationship is so important, so that that patient feels that they can open up and say, well, I presented for chest pain, but really what's been going on is, you know, I just got evicted from my apartment and I have no place to live, and this is what's been going on. And through that point, we then as nurses can really start to be powerful change agents for our patients and really have a therapeutic relationship with them. Through the therapeutic nurse-patient relationship, nurses can be able to encourage reluctant patients to disclose relevant information, and to help our patients become aware of how stress and anxiety can affect their health. Nurses need to always be keen observers and also be really good at interviewing their patients. I always think of us as like the investigators and the detectives of overall patient health. We need to collect the data related to the patient's current and past medical illnesses, their physical complaints, their health history, their manifestations of stress, and take an inventory of their past and present coping patterns. We can go through a stress assessment checklist with them, and there are screening tests that we can use. We have, of course, if we think that someone is under an extreme amount of stress and potentially could be suicidal, there are many validated tools such as the Columbia Suicide Screening Tool that can be used. And there are many other tools similar to those that can help us better assess different types of stressors or different situations for patients and make sure that we're doing the appropriate interventions. Our physical exam of the patient. So we're going to go through the body systems and look for physical manifestations of stress. So on the GI side of things, when we're looking at our GI assessment, we're going to be aware of any reports of constipation, diarrhea, dry mouth, and nausea. When we're looking at the patient's skin, we're going to look for diaphoresis or pallor. Are they sweaty? Are they pale? What else are we seeing related to their skin and their just general presentation? From a neurological standpoint, we're going to listen to our patients talk about their sleep patterns. Do they have insomnia? Are they fatigued? Are they having headaches? Are they restless? With our cardiovascular assessment and our respiratory assessment, we're going to look for tachycardia, and we're going to look at how fast are they breathing. Endocrine and urinary signs, hyperglycemia, increased blood glucose when patients are under stress, and how frequently are they going to the bathroom. And then we're going to monitor the symptoms. We're going to look for sluggish or stiff movements, and we're going to look for muscle tension. We also will look at behavioral habits. Are we seeing signs of cutting, fingernail biting, evidence of crying? Are their eyes puffy and red? All those physical manifestations of stress are sometimes very, very apparent, and we can pick up on them right away when we're assessing our patient, or they may not be apparent, especially when our patient has effective coping mechanisms. So you really have to be a very keen observer and do a really good physical assessment to make sure that we're assessing for all the different signs and symptoms of stress and how they potentially can manifest themselves. And of course, we have some diagnostic tests that can be used. So diagnosis of anxiety and stress-related disorders, um, however, primarily come from patient interviews. We can use medical testing, though, to rule out any medical underlying causes, and also any adverse responses to medications. We can look at diagnosis of psychiatric disorders that requires evaluation by a trained mental health professional. So I think one of the most common examples of I can give of this is, I hear a lot of people saying, oh, that person is depressed or that person is bipolar or any of those things. So if we're going to truly have a diagnosis of a psychiatric disorder, which those two are, the only people that can make those diagnoses are usually a psychiatrist or an advanced practice psychiatric nurse. Different cultures perceive stress and coping in different ways. The DSM-5 can be used to assist healthcare providers in interviewing patients as part of a comprehensive mental health assessment. The CFI is a series of 16 questions designed to assess a patient in 4 areas. They look at the cultural definition of the problem, the cultural perception and cause and support, cultural factors affecting coping and past help-seeking behaviors, cultural factors affecting current help-seeking behaviors. As nurses, we always have our independent interventions that we can do, starting with the use of therapeutic communication. When we talk about stress and coping and nursing interventions, I always want you to think about the use of therapeutic communication. We are going to always encourage our patients to maintain or achieve optimal health. As nurses, that is like our highest goal and possibly one of the most rewarding outcomes for us as nurses. We want to assist our patient in identifying strategies to help meet those goals. These can be cognitive behavioral interventions, education and non-pharmacological relaxation techniques, encouraging patient and family participation in support groups. We as nurses can just validate a patient's feeling. Again, think back to that video that I played about empathy in my last lecture about safety, validating someone's feelings. You don't necessarily have to have those same feelings or maybe even understand them, but you can just say, I can't even imagine what it feels to be in that space, and validate what that patient is going through is very real for them and that you are there to help them. Reinforce positive coping efforts, help to identify successes in a person's life, try to bring out those bright spots, and then as always, we are advocates for our patients. We then will work with our collaborative therapies for patients having moderate to severe difficulty coping with stressors. We can always use psychotherapy. When I worked in transplant, we always had a psychologist and a psychiatrist that was on staff because, as you can imagine, going through let's just say, a liver transplant is a very life-changing event. And these people are very good at treating anxiety or other psychiatric disorders that can manifest themselves, especially when people are under extreme stress. They can address symptoms that may simultaneously warrant hospitalization. We can help protect our patients from environmental stressors as they're working through these challenges, and they can also potentially add the supportive group therapy. So when patients, I've seen this in transplant patients, I've seen this with stroke patients, those are very profound medical events and life-changing things that happen. And the addition of the group therapy can be very, very helpful to make these patients not feel alone in their struggles with their health, things that are specific to those diagnoses. We can also use cognitive behavioral therapy, and I am a huge proponent of CBT. So the goals of CBT are to enhance a patient's problem-solving skills and their coping skills. The role of the patient's thoughts and attitudes are very important. And exposure-based CBT combines different CBT techniques with exposure to controlled versions of a situation that triggers their anxiety. So if they're working with a therapist, the therapist is going to, in a very controlled way, expose them to maybe a slightly different version of something that triggers anxiety for them, but then work through enhancing the patient's problem solving and coping skills with a minor exposure to that anxiety or that trigger. We always have pharmacological therapies. The goals for pharmacological therapies are to manage symptoms and alleviate distress. They are most successful when combined with psychotherapy, and medications may be required for either short or long periods of time. We have benzodiazepines. They are a short-term treatment during acute anxiety episodes. They are very addictive and not recommended for use for more than a few weeks. So think about Xanax. You can think about Ativan. Those are probably some of the more common ones. Valium. Those are all benzodiazepines. Long-term use may cause permanent cognitive dysfunction. Antidepressants for long-term management of some anxiety disorders are available. So we have our SNRIs, our serotonin norepinephrine reuptake inhibitors, used to treat general anxiety disorders. We have our SSRIs that are helpful in treatments of phobias, OCDs, or panic disorders. We also have tricyclic antidepressants that are often used to treat obsessive compulsive disorders. And then you can see beta blockers such as propranolol, which has been used in the past to treat performance anxiety, but that's not generally accepted anymore. But sometimes you do see very low doses of beta blockers prescribed for underlying anxiety. There are herbal supplements, but none are conclusively proven to be effective. They can cause various side effects, and patients should always consult with a primary healthcare provider before taking. We're down to our lifespan considerations. So, children and adolescents, normative stressors that all children face, may also be stressors that many, but not all children face. Normative stressors may include situations that would not be stressful for adults. And then these normative stressors change as the child ages. So think about each different age group of children. When you go from toddler to preschool, those normative stressors for each of those age groups are going to look very different. Non-normative stressors that very few children or adolescents face but produce higher stress levels. These non-normative stressors can be toxic if the child or adolescent does not get the needed adult support. They can influence a child's health into adulthood. They can put the child at risk for increase of chronic diseases. And non-normative stressors, with those, we have to look at the prevention of toxic stress, and that would often require the intervention at a family, a society, or government levels, depending on what the non-normative stress is. There are developmental aspects of stress when it comes to children and adolescents. Some degree of anxiety is normal in early stages of development. Toddlers learn what's dangerous and non-dangerous and cope with fear. They have general fear of strangers when they're younger, or they have separation anxiety. New stressors at school age or adolescence. If a child does not learn how to cope with a stressor, does not get the appropriate support, that's when the child can develop anxiety. So if that child doesn't get the support, maybe during a drop-off period when they're transitioning at a new daycare or something, that can potentially create a stressor that can lead to anxiety for that child if they're not properly supported, maybe by the teachers that are in that classroom. Nurses are challenged to differentiate between true anxiety disorders and normal developmental stressors and fears. Psychosocial assessments should be age and developmentally specific. As nurses, we have to be aware of language children use to express stress and anxiety. It is not going to be the same words that adults use. Children may convey stress by expressing negative thoughts about themselves. Children can be exposed to constant minor stressors that may be more stressful than one large stressor. And anticipation of a major stressor may be more stressful than the actual experience for a child. With adolescents, assessment should include interviews with the patient and the parent individually. We're going to encourage adolescents to be truthful about stressors. So we want to try to establish that therapeutic nurse to patient relationship so that they can be truthful about bullying at school. They can be truthful about different dynamics with their parents and things like that. We may want to ask the patient if they prefer a provider of the same gender at that age. There are assessment tools developed specifically for children and adolescents that we are going to use. We're going to teach coping strategies to both the child and the parent when we're dealing with adolescents. Cognitive behavioral therapies are a great tool with adolescents. And then discussion of treatment methods should focus on teaching multiple coping strategies rather than pharmacological intervention. I think this is pretty intuitive that you're going to want to teach as many different coping strategies and try as many different things as you can before we're getting to that point of prescribing for these adolescents. Many of the medications that are out there today are not approved for children. Some increase the risk of suicide. If you've ever read any of the information, especially about many of the medications that treat anxiety and depression, that is definitely one that is a higher risk for younger kids. And then we teach the patient, the parent or the guardian about the risks associated with medication use and why that's not the good first option most of the time. We're going to move on to older adults. So stressors are often related to the aging associated changes. Many of our hospitalized patients are of a geriatric population, and you guys are seeing this in clinical. Isolation or loneliness can lead and cause further stress. Modern technology also can be a stress. If you've ever helped someone who is probably in their 80s or 90s try to use a cell phone or a computer or try to fix something for them, you can see how stressful it is. Signs and symptoms can include alterations in sleeping patterns, eating habits, self-care. They can have general complaints such as headaches or pains. They may have tachycardia. They may have gastrointestinal problems. They can develop negative feelings or attitudes about things. They can have mood swings, frequent crying, poor judgment, or lack of concentration. Older adults are more likely to report physical discomforts before mental or cognitive problems, especially different generations of people will present discomforts and challenges many times over in a physical way before they even start to talk to you about how it's affecting them in a mental way. I recently had a patient who, I saw multiple times, and every time it would be that there was a headache and this pain in the neck and the shoulders and the burning. But what really was going on after that therapeutic relationship was established is that there was a lot of unresolved trauma and stress from very early on in their life that just had never been dealt with, but had bubbled up to the surface and then was manifesting itself physically. Diagnoses for older adults can be complicated by pre-existing physical illnesses or cognitive changes. Fear of stigmatization is also something that we need to consider when we talk about our older adult populations. Alterations due to anxiety and stress may be hard to identify because older adults often have better emotional control or coping abilities. They've learned how to manage along the way. And older adults tend to use more passive emotion focused coping strategies. They may avoid problems or withdraw from their activities rather than face the stressors. Those who maintain social circles, remain physically active, have better mental and physical health. Social coping strategies have greater effect in reducing stress and anxiety than individual or personal coping strategies. Some older adults may be candidates for cognitive behavioral therapies or medications, but again, this is another group of people we have to be very careful about the use of medications and the potential drug to drug interaction.